All right, everyone. Welcome back to another of our lectures of the cardiovascular system. And continuing in this lecture, we are going to keep looking at the heart. In the previous lecture, we looked at the microanatomy of the heart and the different types of cardiomyocytes. And today, we're going to look at the electrical activity of the heart. So before we begin this, I ask that if you struggled at all, which most students do, if you struggled at all with action potentials in neurons or in muscle cells, go back and review that. And the same if you struggled with the excitation contraction coupling and the cross bridge cycle in skeletal muscle, go back and review that, because that is going to come into play quite a bit in today's lecture, especially the action potentials. So I also want to apologize if my voice sounds off. We've got some weather change happening here, and that always aggravates my sinuses, my allergies, so I'm not feeling at my peak today, so I apologize if my voice is distracting. But as always, let's start with our not really attendance questions. First, during depolarization of a neuronal action potential, what ions are moving and in which direction? Next, what is the difference between autorhythmic cardiomyocytes and other cardiomyocytes? Go ahead and pause the video, try to answer those. Hopefully you've done that. Okay, so let's see what the answers are. During depolarization, that's when the cell is becoming less negative, more positive on the inside of the membrane compared to the outside of the membrane. So during depolarization of a neuronal action potential, what ions are moving and in which direction? Well, remember, sodium is always leaking into the cell and potassium is always leaking out of the cell. So both of those things are happening. But during depolarization, we've actually got the voltage-gated sodium channel open. So sodium is both leaking in and it's also flooding in through that voltage-gated sodium channel. Next, what is the difference between autorhythmic cardiomyocytes and other cardiomyocytes? Well, they're both muscle. They're both cardiac muscle. That's what cardiomyocyte means. It's a cardiac muscle cell. But most cardiac muscle cells are involved in contraction. So we call those contractile cardiomyocytes. And they behave like most muscle. They contract and relax when stimulated. But autorhythmic cardiomyocytes actually are not involved in contraction at all. Instead, these cells are going to generate electricity. They're going to generate their own action potentials at a steady rate. That's what the rhythm part is. Auto, completely on its own without any input from the nervous system. Rhythm at a regular rate. So we saw them at the end of the last lecture. We're going to see them here in just a moment. But these are special cardiac muscle cells that generate their own action potentials at a regular rate. Okay, so here's the slide that we saw at the end of the last lecture. This was showing us the interior of the heart. We are looking at different cardiac muscle. We could see around the atria, it's very thin, and that's because the atria really are not involved in contraction all that much. They do squeeze just a little bit, but not much. We can see the walls of the ventricles much thicker, but we were concerned really with these yellow areas. These were those autorhythmic cells or autorhythmicity cells. Sometimes they're called nodal areas or non-contractile cardiomyocytes. All those things really mean the same thing. And up here at the top of the right atrium, right next to where the superior vena cava enters, is one of those patches. Now, here it's yellow. If this were a real heart, it would not be any different than the rest, the surrounding tissue. It would all look the same. So here, the SA node, this is a guy called the pacemaker of the heart. And that's because on its own, it is completely capable of generating an action potential about 100 times per minute without any input at all from the nervous system. If you were to take the heart out of the body and put it in a jar, this guy would keep the heart beating by generating his own action potentials. But when he generates an action potential, that spreads down and across the atria. A better way to say that is every time he depolarizes, depolarization spreads across and down the atria, and then he will repolarize, and repolarization spreads across and down the atria. Now, since the entire heart practically is muscle, every time this guy depolarizes, that electrical signal, that action potential, can spread through that muscle. And it's really, really efficient because remember, we have those gap junctions to aid in that spreading of the action potential. Now, when that action potential spreads, when it's spreading across and down the atria are depolarizing. But some of that depolarization is going to reach down here to the bottom of the atrium, right next to the ventricle, right next to the valve, the tricuspid valve there. Here we have another one of those nodal areas called the AV node, or the atrioventricular node. When an action potential, whether we're talking the depolarization wave or the repolarization wave, when that gets to the AV node responds by generating an action potential of his own. So when depolarization gets there, he will respond by depolarizing. When the repolarization gets there, he will respond by repolarizing. So this guy, the AV node, coming off of him, sort of like a tail, is what's rather like a cable of that autorhythmicity tissue. This is called the bundle of His, or the atrioventricular bundle. The bundle of His, or the atrioventricular bundle. Every time the AV node generates an action potential, that action potential is going to spread down the bundle of His, like electricity traveling through a wire. We saw that the bundle of His splits into a left and right AV bundle, or bundle branches. They are going to travel down towards the apex of the heart and then reflect back upward, and they branch like trees or like a net or a spider web all through the walls of the ventricle. We can only see them right here, but they're running through all of the walls in all directions. We're just seeing them here because that's how the heart is cut. And that action potential is now traveling up through those, this is called the Purkinje fibers, or the subendocardial conducting network. Purkinje fibers, or subendocardial conducting network. That action potential is traveling upward through them, and then through the other muscular cells making up the walls of the ventricle. So let's put all that together. SA node depolarizes, sends an action potential out across and down the atria depolarize. It also sends that depolarization down and it hits the AV node. The AV node responds by generating an action potential of his own. That action potential spreads down the bundle of His, down the left and right bundle branches, up the Purkinje fibers, and across the walls of the ventricle. Same thing happens with depolarization. It's just with repolarization. The depolarization happens first, the repolarization comes right behind it. Now, remember, every time we apply an action potential to a muscle, the muscle responds to a stimulus. How does it respond? It's going to contract. So we're going to see that tied into what we just said. So keep everything we just said in mind. But first, we're going to look at the action potential in more detail for really this SA node, but it could be for the AV node, the bundle of His, the bundle branches, or the Purkinje fibers. Because in a healthy, functioning heart, we said the SA node depolarizes 100 times a minute. Well, that means so does the AV node, so does the bundle of His, so do the bundle branches, so do the Purkinje fibers, because it's the same action potential traveling all that way. But before we move on, I do want to point out, if something were to happen and the SA node were not functional anymore, the AV node is capable of generating action potentials on his own. If something were to happen to the AV node, the bundle of His can generate action potentials. So can the bundle branches. So can the Purkinje fibers. They're all capable of generating action potential. The drawback is the SA node generates action potentials about 100 times a minute. On his own, the AV node generates action potentials about 60 to 80 times a minute. 40 to 60 times a minute. 40 to 60 times a minute. And the AV bundle, or the bundle of His, does maybe 20 to 40 times a minute. And it just keeps dropping off the further we get. So really, if something happens to the AV node, the bundle of His takes over, but we're going to have to do something about it really quick because that could not keep the heart going at a fast enough pace. So now let's look at the action potential for, we're just going to say it's for the SA node. Okay, here is the action potential for the SA node. Here is the next action potential for an SA node, and it just keeps repeating. In a healthy functioning heart, there would be 100 of these waves per minute. So let's look at this because it looks different from the action potential graph that we saw back in Bio 137. The first thing I will say is these numbers over here on the left, those were super important when we were talking about neurons and skeletal muscle back in Bio 137. In Bio 139, you are not responsible for knowing these for lecture. Don't worry about it. Know that as we go upward, we are getting less negative, more positive, and as we go downward, we're getting less positive, more negative, but don't worry about the specific numbers. Instead, we want to know what's happening at each of these stages. Now, I said that the SA node was the pacemaker of the heart. He sets the rhythm for the entire heart. And down here, starting at this very bottom point, we can see that there is this slow depolarization coming upward. This is called the pacemaker potential. And that is because the SA node, and all of the others, but the SA node has this special type of sodium channel that on its own opens about 100 times a minute. It's similar to a voltage-gated sodium channel, but on its own, it opens about 100 times per minute. And when it opens, sodium starts coming in. Once we get to threshold, don't worry about what voltage it is, but once we get to threshold, something happens. More voltage-gated sodium channels open, but more importantly, voltage-gated calcium channels open. At the voltage-gated calcium channel opening, we get a very sharp rise. It happens very quickly. This is depolarization. Once we get to the peak, just above 0, those voltage-gated sodium channels close, those special sodium channels close, and the voltage-gated calcium channels close. The voltage-gated potassium channels open, and we come back down. Now we're repolarizing. We get back to rest, and now the voltage-gated potassium channels close, and those special sodium channels open again. And now we go through the whole process again, and again, and again. Now, a couple of things to notice. This part right here is due to that calcium. Calcium has a double positive charge, so it gets us depolarized pretty quickly. Also notice, between one action potential and the next, there is no period of rest. We get back to what would be considered resting potential, but immediately we go back up, depolarizing again. So there is no period of rest, but there are, at the normal, healthy heart, without any input from the nervous system, this happens in the SA node 100 times a minute and then spreads through that pathway that we saw. Now, this was the graph of an autorhythmic cell. We called it the SA node, but it could have been the others also. So this is an autorhythmic cell action potential, non-contractile. Now we're going to look at the action potential of a contractile cardiomyocyte, the cells in the heart that do contract. Now this, when we look at it, it looks also very different from the action potentials we saw in neurons and skeletal muscle, also very different from the action potential that we just saw on the previous screen. But if we look just at the blue, this is the action potential. Ignore this pinkish purple line right now. We'll get to that later. Just ignore it, pretend it's not even there. Look at this blue. This is the action potential that happens in a contractile skeletal muscle. And remember, every time we saw this action potential happen in a non-contractile cardiomyocyte, in one of these yellow areas, we said that it would spread across and down the atria, because those are other cardiac muscle cells. And then once it spreads up through the ventricle, through the Purkinje fibers, it spread across the walls of the ventricles. So the action potentials in these non-contractile cells, they are passed through to the contractile cardiomyocytes. When they are passed to the contractile cardiomyocytes, this is what it looks like. This is the action potential in a contractile cardiomyocyte, the blue line. So let's see what happens. We are completely at rest, and again, don't worry about the numbers. Just know what they mean. Down here, we are completely at rest. When the action potential comes, we go very quickly, pretty much immediately, from complete rest to completely depolarized in an instant. That is because there is another type of very special sodium channel. It is called a fast voltage-gated sodium channel. It's voltage gated, it opens very quickly, and it allows a lot of sodium through all at once. So we go from completely at rest, depolarized, or polarized down here, and completely depolarized right here, all in a moment. Once we get to this peak depolarization, a few things happen. First, those fast voltage-gated sodium channels close right back. Second, voltage-gated calcium channels open. Third, voltage-gated potassium channels open. Which way does calcium move? Well, it moves into the cell. Which way does potassium move? It moves out of the cell. They are both positively charged. We've got positives coming in and positives going out. Well, the result is almost a flat line. It's slightly repolarizing, but it's pretty much flat. We call this the plateau phase. And that is because calcium is coming in and potassium is going out. Now, at this point, the voltage-gated calcium channels close. The voltage-gated potassium channels remain open. So calcium stops coming in, potassium continues going out, and so we repolarize back to resting. A few things of note here. First, there is a resting phase. Next, we have to come all the way back to resting phase before another action potential can happen. Because, as we said in the last lecture video, there is a very long absolute refractory period, meaning during this time, even if another action potential were applied, the contractile cardiomyocyte could not have another action potential. It has to come all the way back to rest before it is capable of another action potential. So now, that is the action potential of a contractile cardiomyocyte. How many of them should there be? Well, in a healthy, functioning heart, without any input from the nervous system, we would have 100 of these per minute. Because every time a non-contractile cardiomyocyte has an action potential, it's going to cause a contractile cardiomyocyte action potential. And lastly on this graph, now we're going to look at the purple line. This is not an action potential graph. This is a tension graph. This is looking at the tension in a contractile cardiomyocyte. As tension goes up, the cell is contracting. As tension goes down, the cell is relaxing. We can see for one action potential, we get one contraction cycle. But more importantly, look at the layout, because the timing here is important. When we get depolarization, once we are fully depolarized, at that same time, we start to get contraction. We get tension building. But then, once we start to repolarize, well, right after that, we start to get relaxation happening. So depolarization is followed by tension building, contraction. Repolarization is followed by tension dropping, relaxation. It's always going to be in that order. So if we go back to look at the heart again, putting everything we've talked about in this lecture together now, the SA node depolarizes, the atria depolarize, the SA node passes that action potential to the AV node, and the AV node depolarizes. Now, while that depolarization travels through, go back to the atria. The atria depolarize, so what are they going to do? They're going to contract. Then repolarization comes through, they are going to relax. Meanwhile, that depolarization spreads through the ventricles, they will contract, and as repolarization passes through, they will relax. And it happens in that order. The atria depolarize and contract, then the ventricles depolarize and contract. So if you were to look at a heart, the whole thing does not contract and relax at once. The atria contract and relax, and then the ventricles contract and relax. That's because there's a delay of that electrical signal passing through. So I keep saying that the heart will beat on its own 100 times a minute without any input from the nervous system. And that's true. Now, that does not mean that there isn't input from the nervous system. There is, from the vagus nerve. The vagus nerve comes down and connects to all those autorhythmic parts of the heart. So does a sympathetic nervous system, because the vagus is part of the parasympathetic. There is a nerve from the sympathetic that also connects to those autorhythmic parts of the heart. And they come mostly from the medulla, is where this information comes from. In the medulla oblongata, there are areas called the cardiac centers. Remember, the medulla of the brain is the part of the brain that handles things to keep us alive without us having to think about it. And one of those areas are the cardiac centers. There's something called the cardioacceleratory center, and another part called the cardioinhibitory center. The cardioacceleratory center does just what it sounds like. It accelerates the heart. It is from the sympathetic nervous system. So it's from the medulla, it travels down to the sympathetic ganglia that we saw next to the spinal cord, and then on to the heart. And what does the sympathetic nervous system do? It tells the SA node, hey, I know you beat 100 times a minute, but we need to beat even faster. So it takes it up to about 120, 130, or even higher. The cardioinhibitory center does just the opposite. It inhibits the heart. It is part of the parasympathetic nervous system. So the medulla sends an action potential or sends signals through the vagus nerve to the SA node and tells the SA node, hey, I know you depolarize 100 times a minute, but let's go slower. Let's go down to about 75 times a minute. So let's think that through now. I said that in the healthy functioning heart, without any input from the nervous system, it depolarizes about 100 times a minute, and we would have a heart rate of about 100 times a minute. But if you feel your heart, unless you are extremely anxious or have something else going on, your heart's not going to be beating 100 times a minute. It's going to be beating about 75 times a minute. Why is that? That's because the key word for resting heart rate is resting. Remember, rest and digest, relax and reproduce. That's the parasympathetic nervous system. When you are at rest and relaxed, your parasympathetic nervous system is telling your heart you only need to beat about 75 times a minute or so. So resting heart rate, 75 times a minute. But I've said a few times, if you take the heart out of the chest and put it in a jar and supply it with all the nutrients that it needs, it's going to continue to beat, even without any input from the nervous system. So now let's use this as a thinking cap question. The thinking cap question is, how fast would this heart beat? Try to answer that without listening to the answer just yet. Well, if it's not connected to anything, but it's still beating, that tells us it's under control of the SA node. How quickly does the SA node depolarize on its own? 100 times a minute. And every time it depolarizes, what happens? It's going to lead to a heartbeat. So the heart would beat 100 times a minute in that jar, as long as it has all the nutrients that it needs. So now we look at an EKG or an ECG. This is something we're going to be demonstrating in lab. If you haven't already, you will be soon. And the ECG or the EKG, there are readouts that we've all seen, like we see right here, and then every time we're in the hospital we see it, on all kinds of medical shows we see it. What is it showing us? Well, first, how do we get it? Well, the device, the heart monitor, is called an electrocardiograph. And it reads out either on paper or on screen to show us the electrocardiogram, which is what we see here. Now, the EKG or the ECG, electrocardiogram, this is not an action potential graph. That's not what we're looking at here. Instead, it is a visual representation of all of the electrical activity in the heart during one heartbeat. Now, it doesn't directly show us any of the mechanical events, the contract or the relax, but it does show us all the electrical events, the depolarization, the repolarization. So, as long as we know what electrical event happens where, we also can look at this to see where the mechanical events are. So this really does show us everything that happens in one heartbeat. We're going to, like I said, look at it in lab, but let's briefly look at it here also. When we have an EKG, we have the P wave, the QRS complex, the T wave, and then it repeats. We also have these areas in between that have their own names, but I typically just refer to them as the flat spot between P and QRS, or the flat spot between QRS and T. They do have names. I just refer to them as that. Makes it a little easier on you, I think. So let's see what happens at each of these areas. Well, right before the P wave, right here, we get depolarization of the SA node. And what did we say happens when the SA node depolarizes? That depolarization spreads across and down the atria. So the atria depolarize. That's what the P wave shows us. Where it goes from flat to a wave, that wave is the time when the atria are depolarizing. So we have atrial depolarization. Well, every time some part of the heart depolarizes, what did we say happens? It's going to contract. It's going to squeeze. But in the heart, we don't really call it a contraction. We call it systole. So, following atrial depolarization, in this flat spot, we have atrial systole. The atria squeeze a little bit. Now, during the QRS complex, it's big and spiky. That's because there's a lot going on there. There's 3 different things that happen during the QRS complex, and they kind of overlap each other. So we could say them in a few different orders. I'm going to say, well, we've already been talking about the atria. Let's finish talking about the atria. P wave was atria depolarized. The flat spot after the P wave, the atria went into systole. Well, the order would tell us that after systole comes repolarization. So one thing that happens during QRS complex is atrial repolarization. Every time one part of the heart repolarizes, the next thing that happens is that same part of the heart goes into diastole. So we've completely gone through the atria now. P wave, atrial depolarization. Flat spot, atrial systole. QRS complex, we said atrial repolarization followed by atrial diastole. Now, one more thing happens here, because by this point, now that electrical signal, that depolarization wave has spread through the Purkinje fibers and is spreading across the walls of the ventricles. So the third thing that happens in the QRS complex, ventricular depolarization. Once the ventricles depolarize, what's going to happen? Well, when one part of the heart depolarizes, the next thing that happens, so here at this flat spot before the T wave, this is where we get ventricular systole. Ventricular depolarization was during the QRS complex, so right after that, we get ventricular systole. The ventricles squeeze. It's not an electrical event. That's why we have this flat space right here. It's a mechanical event. Now we have the T wave. What happens right after ventricular systole? Well, the ventricles are going to repolarize. We get ventricular repolarization. And following repolarization, that same part of the heart will always go into diastole. Here, right after the T wave, the flat spot, ventricular diastole. That is one complete heartbeat on the EKG. But things can go wrong, and we can look at an EKG to see, based on what a normal EKG looks like and what's happening at each of those spots, if the EKG looks different, what does that tell us? Well, when something goes wrong with any of those electrical areas of the heart, those autorhythmic areas, it's called an arrhythmia or a rhythm disorder. Now, an arrhythmia is not a disorder. It is a class of disorder. There's different types of arrhythmias. For example, fibrillation. There is atrial fibrillation, not such a big deal. There is ventricular fibrillation, a really big deal. AFib, atrial fibrillation, the atria are kind of mishandling action potentials. They're just kind of happening haphazard, and the atria quiver. Ventricular fibrillation, same thing except down in the ventricles, but since they are involved in moving blood, it's a really big deal if they start to quiver. Next, an ectopic focus or ectopic pacemaker. These are the same thing. Well, I said that if something goes wrong with the SA node, the AV node can take over. If something goes wrong there, the bundle of His can take over, on and on and on. When some part of the heart, other than the SA node, becomes the pacemaker, it's called an ectopic focus. Similarly, if some other part of the heart that is not normally an autorhythmic cell becomes an autorhythmic cell, that can cause an ectopic focus. That's really common in, for example, cocaine use or extreme use of caffeine. Those can happen on occasion. Junctional rhythm. Junctional rhythm is when the SA node no longer functions. And the result is we don't see a P wave, and the QRST is happening much slower, because if the SA node is no longer functioning, the AV node takes over. We don't see a P wave because the SA node causes the P wave. We see the QRST happening slowly because the AV node does not depolarize as quickly as the SA node does. Heart blocks. In a heart block, this is when something is going wrong with the AV node. The SA node is fine. The AV node has something wrong with it. Now, the higher the number, the worse condition the AV node is in. So a first degree heart block, the AV node, it's not doing well. It's not able to do its job as well. So we have the P wave from the SA node. There's a longer than normal delay, that flat spot between P wave and QRST. And then we get a QRST. There's a longer delay because the AV node is not responding quick enough. In a second degree heart block, that delay is even longer, and the result is sometimes we don't even get a QRST. So we'll have P, long delay, QRST. P, long delay, another P, and then QRST. So the ratio of P to QRST is off. We have more P waves than QRSTs. And in a third degree block, or a complete block, what happens is the AV node no longer functions at all. It has died off. So the SA node is pacing the atria at the normal rate. We see normal P waves, but the bundle of His is taking over to pace the ventricles since the AV node is no longer there. The bundle of His, we still see QRST, but the QRST are much slower. Like we said, about 40 times a minute. So P wave is happening about 75 to 100 times a minute. QRST are happening about 40 times a minute because they are completely out of sync with each other. So here are a few graphs. We will see more of them in lab. This is normal sinus rhythm. This is a normal heart. We see the P, QRST, P, QRST. This is junctional rhythm. We do not see any P waves before the QRST. And the QRST is slower. Up here, we can see they're happening, at a regular rate. Down here, quite a bit slower. Second degree heart block, we can see a P, QRST, P, P, QRST, P, P, QRST, P. So this is a second degree heart block. And down here we have ventricular fibrillation. We can see that there is nothing at all making sense here. That's just very haphazard. This is when we would see someone pull out the paddles and shock the patient, trying to get them back into a normal rhythm. All right, so that is it for the electrical activity of the heart. This is one of those that you should probably watch more than once. Also, use it as you're studying lab. And if you have any questions at all, please reach out. Let me answer them. All right, take care, and I will talk to you next time.